Good morning. It is 8:32, 8:33, so we're going to get started with our webinar. And we thank you for joining us today. We're pleased to welcome Dr. Ryan Jennings, the Chief Medical Officer at HSHS St. Anthony's Memorial Hospital, to join us for a look at COVID-19 updates and recommendations. We appreciate that many of you have already submitted questions, and we will cover those as well as others we can add to the chat box as we go along. Please remember to stay on mute during the call. I've got some feedback right now, so you please make sure that your video is on, or you're on mute, your microphone, and that your video is off. And also just another reminder, questions, please use the chat box for those. First of all, we want to thank ACRA Builders, this week's webinar sponsor. ACRA has been a regional leader in the construction industry for over 45 years. They specialize in design, build, construction management, general contracting, general construction and renovations, concrete construction, and pre-engineered metal buildings. As we go forward, so let me introduce Dr. Ryan Jennings, who as the Chief Medical Officer at St. Anthony's Memorial Hospital, his duties are to raise the level of quality throughout the hospital and lead physicians to evolve the clinical. Man, Ryan, this is hard to repeat. To evolve the clinical challenges being driven by healthcare reform by promoting alignment between the hospital and physicians. Dr. Jennings practices as a hospitalist as well as serving as the Chief Medical Officer for 4 hospitals in the Hospital Sisters Health System. Those include St. Anthony's Memorial Hospital here in Effingham, St. Mary's Hospital in Decatur, Good Shepherd Hospital in Shelbyville, and Holy Family Hospital in Greenville. He is a board-certified specialist in internal medicine and pediatrics, as well as credentialed as a certified physician executive. A native of Olney, Ryan Jennings moved to Effingham in 2002 and joined the hospital's medical staff. He took on the part-time role as Chief Medical Officer in 2012 and assumed the role full-time in January of 2015. So welcome, Dr. Jennings.
Well, Chief Barbara, you make me sound awfully important.
Well, you have all the answers, right?
I do, it's kind of interesting. I really do appreciate the opportunity to come and speak, and who would have thought that maybe the timing of this conversation is right on with what we're seeing, with what we're starting to see within the community. And, the conversation earlier might not have seemed quite as relevant as perhaps what we're about to face. So really my biggest goal today is to leave a reasonable amount of time for questions and answers. So please be putting those into the chat box, and I'll try to kind of hit on those as they pop up throughout kind of a review of of the journey that we've been on. Above all else, that this journey is actually remarkably short. It feels like half of my life, but really, when you think about it, the first case in the U.S. Well, it wasn't diagnosed till January 20th, and we've only had it in Illinois since the 1st of February. So we're right in that region. So in the grand scheme of things, this whole saga is only about 6 months old. And as a physician, I can assure you that medical science doesn't usually move that fast. And so there's a lot of unknowns, but I think there's been a lot of rapid assimilation of really good minds around this, and hopefully I can work to kind of summarize some of those things for you. So I want to kind of give you a state of the state, a little bit of situational awareness of kind of where we're at with the disease. Maybe a little bit of the science, just very briefly, to help understand kind of how it's spread and why we talk about the mitigation strategies that we do. Maybe contrast it with the flu. That's a very common question I see is, how is this different than the flu, and what's all the hubbub about? Speak specifically to the prevention strategies that we've been out there, have been put out there, as well as testing and ultimately treatment options. And some of the long-term consequences that are undefined, but are becoming almost as big of a topic as the acute disease itself. Definitely want to spend some time on what you can do as businesses and business leaders to reduce your risk, and hopefully, if we reduce this risk overall, collaborate through the Restore Illinois plan to make sure that we don't slip backwards. So that's kind of my lineup for the day. That I talk fast. I think anybody that knows me knows I talk pretty fast. So that will not take the entire time. And again, I want to leave plenty of opportunities for questions. So really, when you look at the numbers, like I said, given the fact that this thing just started basically 6 months ago, globally, we're up over 21 million cases with about 760,000 deaths. So again, if you contrast that to the flu, typically in a normal influenza year in the U.S., we'd only see about 61,000 deaths, and we're already up to 171,000 deaths in the U.S. So deadlier than the flu for sure. So I think that's important to know. Within the state, we've had about 212,000 cases so far, 7,800 deaths. And one of the big topics is the percentage of folks that are positive. So statewide, right now we're running about a 4.5% positive rate. Now locally, so far we've had about 285 recorded cases, and just the one death that I think all of us kind of recall the conversations around that. But we have about a 5.9% positive rate right now, so a little bit higher than the state average. But as you look across our region, so the state plan now basically redivided the Restore Illinois plan to align with our trauma region. So we're in Region 6, both for trauma as well as now in relation to monitoring that's going on with COVID. And across the region, we're only at about, somebody may need to mute there. Across the region, we're only at 2.2%, which is good news because if
You guys better hurry up because he's already
if that number drifts up significantly, we end up over 8%. That's when things get very interesting. Many of you are probably aware that Region 4, which is kind of the Metro East region, recently did have to move into mitigation strategies around maintaining their status in Stage 4 of the Restore Illinois plan. And we'll touch on that a little bit. But as a region, we actually look favorably both with the percent of overall positive tests as well as our hospital bed utilization rate. So right now across Region 6, only about 64% of our med-surg beds are filled, and only about 11% of our beds are in use. So that's good news. We've got room, but still a significant uptick locally in what we've seen in positive tests. So we sure want to pay attention to it because the last thing we want to do is move backwards into mitigation strategy. So that's a little bit of kind of where it's at. It's just as far as the numbers go. But the interesting about this virus, when you think about it, is coronaviruses aren't a new thing. We have monitored coronaviruses for many years, but what happened here is something that we see in viruses from time to time when something will happen and they take on a completely new structure. So even though they're in the same family, just like a basset hound and a dachshund are in the same family, they look incredibly different. And viruses occasionally will do the same thing, where they have a significant mutation or something that triggers it, and then when it becomes in the population, nobody has an immune system that's ready to deal with it. So it's a completely new, so thus the novel coronavirus name that it carries. They call it coronavirus because it's actually a pretty cool looking virus. It kind of looks like the sun. It's a little round thing with little spikes coming off of it. But those little spikes are what help it to attach when it gets into your lungs and then causes basically the lungs to start to have difficulty where they collapse upon themselves. If you fill up with mucus, they start to collapse in on themselves, kind of like if you put water in a water balloon instead of air. It becomes very heavy. It just doesn't do what a normal balloon would do and float around. It collapses in on itself. So they got a lot of DNA analysis around it, and it looks similar to the bat coronaviruses. And so there's a lot of speculation that maybe it originated in bats, but we definitely don't know with 100% certainty where this thing totally came from. We know how it moved across the globe, but how it got from person to person or from an animal species to a person, we don't know. But we've certainly seen it in lots of different viruses in the past. The other thing that makes this particular thing so ugly compared to, say, influenza is what you've heard about probably on the news, which is this R naught value, R zero value, or the effective reproduction rate, which basically gets the idea that if I go out into the community and I'm carrying the virus, whether I'm obviously symptomatic or I'm even asymptomatic, how many people am I likely to then cause to acquire the infection with close contact? So the flu typically has a value of 1.3, meaning if you walked out in the community with influenza, for every person or every 10 people you meet, you might infect three of those 10, 0.3 of the 10. So so the 1.3 is a ratio basically of how many people you would expect to infect. This thing is all the way up at 2 to 2.5. So, about 8 times more infective than what influenza would be. So, very difficult to control it. And so, when you look at the strategies that they're trying to implement around reducing the spread of the virus, that's the whole idea is basically to try to reduce this R effectiveness, infective reproductive value, get it below 1. The idea of once it's below 1, then the virus burns itself out. If you go out into the community and you don't infect but even one other person, then eventually you recover, the other person recovers, and the virus burns out. So after some of the mitigation strategies that they put in some of the countries that have already dealt with this, that value drops dramatically and has been as low as even 0.4, zero point 0.5. And so they see some effect on eradication. How's it get spread? Typically, the main route of spread is definitely respiratory droplets. That when you cough, sneeze, speak. Now that we do all these video conferences, I think I have to clean my computer screen about 5 times a day, just because it's amazing how much you spit when you when you talk to a computer all day. So that's definitely the major way that it's spread is just through speaking, coughing, sneezing, those types of things. And that's where they think the role of the mask comes in. There's a lot of debate about whether or not those tiny particles that can make it through the mask carry enough virus to truly be effective. And there's still a lot of debate about how much it's spread on surfaces. We definitely think that cleaning surfaces is important, especially again areas where there's large exposure. But how long it lives surface, and even if you can find the virus on the surface, whether or not that virus is still able to reproduce itself, if you touch your face or something after touching a surface, is still an area of considerable debate. We do know that it seems to have to go in through a mucous membrane. You have to have it come in contact with nose, mouth, eyes, those types of things in order to start replication. There's not been anything that shows this virus to be bloodborne or a concern if you have a abrasion on your arm and somebody sneezes on your arm, that you're going to have COVID or anything like that. So we really think that the primary way that this virus gets spread is through actual droplets and probably less to do with aerosolization. The hard thing that also makes this disease difficult, though, is that most people are putting out a pretty large amount of virus in their respiratory droplets for probably 2 to 3 days before they even start to get sick, and they don't become really sick till day 4 or 5. So it's very common for folks to be out in the public shedding pretty large amounts of virus and completely unbeknownst to them. There's also a lot of conversations about asymptomatic spread, and that was one of the other questions that was out there is what percentage of people seem to be asymptomatic when you look, they've actually had the disease. This is where the titer testing, when people talk about doing the blood test to see if you ever had infection or not, actually becomes the really useful tool to see, does this person have antibodies? I mean, they had the disease at some point, they didn't even know it, and yet, they have antibodies that presumably may offer protection from the illness, but that still remains to be a definite an unknown as well. Those numbers look to be maybe as much as times higher than the number of people that become sick. So there seems to be a very large number of folks that when you go out and you check to see if there's antibodies, which is good news, really. That says that, there is opportunity for, spread of immunity across the population without having everybody, get so sick that they end up in the hospital, and a fairly large number actually convert and become what we call seropositive, meaning they have titers without having been sick. So that's good news, but that doesn't mean those folks may not be able to spread it from person to person. So we still have to be a little bit cautious, just recognizing that even when you're with somebody that's asymptomatic, it's very possible that they still could be carrying the disease. So those are, I think, probably the biggest differences that you see that why this virus has got such a different shape than what we see with influenza. It is a little bit deadlier. It's definitely more contagious, and this asymptomatic carriage state really is problematic when it comes to trying to prevent the spread of the disease. So when you think about what we put out there for preventing the spread, the focuses have really been upon hand washing. You pick the virus, hand washing is the right answer. Whether we're talking about influenza or we're talking about, coronavirus, or you're talking about just any of the jillion of other viruses that we all deal with year after year, hand washing definitely makes a significant effect on the spread of all viruses, respiratory viruses especially. And whether that's soap and water for 20 seconds, the old fashioned way, or you use a hand sanitizer that has 60% or so ethanol or alcohol in it, that they're equally effective. So the benefit of the hand sanitizers is they're quick and easy. The caution around hand sanitizers, of course, the concerns that some of them are now methanol based, and so some potential toxicity from using a sanitizer in that situation. I think one of the areas where we see a lot of opportunity for improvement around hand washing, specifically related to COVID, is thinking about it when you touch your face, wash your mask, put your mask on and off. So when you're touching your face or removing it or reapplying your washing your hands before and after masking is probably pretty important because you're coming in contact again with mucous membranes, your nose, your eyes, those types of things. So one of the things that it's not thought about this much. We touched a little bit on surfaces. Surfaces are tough to sort out because definitely cleaning the surfaces and other viral syndromes has been proven to be of significant benefit. It would make sense that it would be of benefit in this scenario, but like I said, at this time, the life of the virus remains a little bit unknown. It's definitely affected by temperature. So, the temperature of the room makes a big difference. Exposure to sunlight makes a difference for this virus. So there's nuances, but it makes sense to be attentive, especially to high touch services in your businesses. Those doorknobs and handles and bathroom doors and, the cash register and all that kind of stuff that are high touch surfaces. You need to be spending some extra time making sure that they're clean. What can you clean with? Almost anything. I mean, that's a little bit of the good news here is that this thing doesn't seem to be a terribly difficult bug to kill with just your normal household cleaning agents. Most of the wipes and things that you pick up are made out of quaternary ammonium or quad, and everybody calls it quad, I think, and that's very effective for killing this particular virus. Of course, the alcohol-based things we talked about. So it's not a horrible virus to kill as opposed to some of the other things that maybe we deal with from time to time. So that's good news. Masking, of course, is the $1 million controversy that is a heated debate at times. The reality is that you don't have to use your imagination. That if I'm sitting here talking and spitting on my computer, if I put the mask on, I'm going to have less spit on my computer. So given that the respiratory drops are really the source of spread, masking makes a ton of sense. And there is a lot of good evidence that it is effective in protecting others from you potentially spreading it. There's some emerging evidence that it may actually protect you a little bit as well, but that's not nearly as evident as what it is that it does reduce the spray of respiratory droplets. And those tiny particles that get through that are what we call aerosolized, they're still not sure that they're a major culprit in the spread overall. So that's where the higher level masks come in. They come in with the idea of both protecting smaller droplets from being able to get through, but they're made to actually seal against your face. So when you breathe in, you're preventing particles from coming in. So when you talk about the N95 mask and things like that, they then take on the role of really being designed to protect the wearer every bit as much as the person that's they're exposing themselves to. That's really the big difference. And an N95, for anybody that's had to have the pleasure of wearing them, is definitely not something that's any fun to wear all day long. So, other than those folks that are in very high risk environments, having to wear an N95 is not necessary and probably not even appropriate. Certainly, if you have any medical conditions that make breathing difficult. The only caution on masking around what you can wear in public, there's pretty good evidence that putting exhalation valves into the mask kind of defeats the purpose. It makes sense if I make holes in it for when you breathe out to make it easier, bigger droplets get through, and that just makes sense. Um, the other piece that I think is easier to do to some extent, and kind of goes hand in hand with not having a mask, distancing. And the masking guidelines are really based upon situations where you're unable to adequately distance. And the 6 foot thing was based upon what they think droplet spread looks like more so than aerosol spread. So again, the idea that the bigger droplets normally don't travel more than about 6 feet. And so the social distancing idea of maintaining a 6 foot distance is huge and does alleviate some of the concerns about situations in restaurants and places of business where folks can separate each other and then safely not have to be wearing a mask. Um, Testing. So testing, is an argument just simply because it creates problems. And one of the questions that's come up is, that how do you handle these cases? Because then they start the process of testing somebody that was in close contact, and the next thing you know, you don't have a workforce. And this is a very real situation right now and is becoming a bigger problem, partly because of folks just wanting to go get tested and then accidentally finding out that even though they weren't sick, they tested positive. They were an asymptomatic carrier, or their household contact got tested, and because their household contact, they live within 6 feet of each other for more than 15 minutes very frequently, then the Department of Public Health and the guidelines recommend that then that person be quarantined as part of trying to control the spread of the disease. This is a tough one because there is some reality of wanting to do some testing to keep an idea of what the disease prevalence looks like. There's also the reality of the workforce and being able to maintain operations. Most recent guidelines for return to work did become more generous. They actually said that for someone that's been sick or in this case, potentially exposed, even 10 days of isolation, as long as 10 days from when they were diagnosed or became ill, of isolation, as long as somebody is fever free for 24 hours without using Tylenol or ibuprofen, and improving in whatever their initial symptoms are, then those folks can return to work. The quarantine instructions are a little sketchier around that because they relate more closely to the last time that person was exposed to whoever their point of contact was. This is a real conversation with the public health department when you get these notifications and exposures. And there's also exemptions for many essential workers. And essential worker is defined pretty broadly, as you recall from when we were able to start to reopen essential work that is basically based upon asking the health department because this person is unable to be replaced in the workforce for whatever reason, whether that's just simply availability of workforce or specialized training, and that they perform an essential function, that you can ask for a letter basically that defines the quarantine more directly. So basically, it would say this person can go to and from work, and that's it. It's not a license to go roam around in society, but it's a ability to go to and from work because they're essential to your workforce. So really collaborating closely with your health departments around getting that type of uh, 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 answer from them is huge. Negative testing is one other strategy, and that's one that we're kind of beating our heads against because oftentimes testing availability is extremely limited, and there are some test centers that are open that behind the most closest one there is Southern Healthcare Foundation has a testing site. The challenge that the testing sites are running into is turnaround time. And because of the high volume of testing that's being performed, when those tests go to the lab, if it takes them 5 days to turn it around, well, if you can just imagine if that was a Monday through Friday person, then they already took out a whole week, and by the following Monday, their quarantine would have been about over anyway. So testing turnaround is really become a major barrier to getting folks rapidly turned back around and able to return to the workforce. Locally, we are working to try to get additional testing supplies. Right now, some of the rapid testing that is available is being reserved for uh, patients that are being hospitalized in order to make appropriate isolation of those folks and keep the workforce safe, or for folks that are returning to a congregated living facility, so nursing homes, prisons, um, uh, group homes, those types of things are the ones that are being tested with some rapid turnaround capability in order to make disposition. But the shortage of reagent combined with then the backlog of cases to facilitate a rapid turnaround has become kind of the rate limiting step for employers. Um, the answer to that one, we are, like I said, looking at multiple systems. I will say yesterday, the University of Illinois' saliva-based testing was granted an emergency use waiver, which is good news. A straightforward testing that has rapid turnaround. They were estimating the ability to perform 20,000 tests a day, and that sounds like a lot, but it's not very many, unfortunately, when depending upon where they allocate those resources. Because part of what we have seen is the reallocation of reagent and resources to areas that are higher in prevalence. So, even when we asked for 10,000 to get 10, because they get redirected to areas with greater prevalence. Hopefully, the university will be able to continue and expand it, and that will give us some options. So I wish I had a quick answer to testing, but at this point I don't. Um, so what's the role of the business in this? I think a few things. One is to hopefully things within the community that keep us from sliding backwards. So as much as it's painful to have to practice some of these behaviors, it's more painful to have a business that's not operating and those types of things. So I think, as big of an inconvenience it is, masking and distancing and doing those things that will help us to hopefully not have a slide backwards in the test positivity rate any further. We've already bumped up a fair amount. Is going to be something that can help us to do that. So as business leaders, I think that's an opportunity to demonstrate that in the public that you are taking it seriously because you do want to maintain your operations. Two is protect employees, so giving them the right type of resources depending upon your work environment to make certain that if they can't socially distance, that they do have appropriate masking, et cetera, so that you don't end up with a cluster of cases within within the business itself, because that could be just devastating to the entire workforce. Even if they do reasonably well, just the outbreak obviously hobbles the operation substantially. So protecting your workforce. Three is protecting the public, so beefing up your sanitation, especially of the common surface areas, those types of things, and trying to accommodate social distancing in every aspect that you possibly can. Mandatory masking when folks enter a store or a business is a challenge, but we've seen a few businesses move to that, and after the initial humbug around it, most of them have not really had much of an issue over it. Once people kind of get the idea, they go ahead and move on to doing their shopping just like they would normally. So although it puts you in a difficult spot occasionally with a customer, and I think the other piece of that is if there's somebody that really can't for whatever reason, then figuring out how do you accommodate social distancing for that individual so that they're able to get what they need, but not potentially expose your workers, yourself, or other members of the public. Um, those are probably the biggest strategies. There's a ton of resources for different businesses, almost of anything you can think of on the Illinois Department of Public Health, CDC websites. All have tons of information and strategies. Um, but I think if I were in business that where I was right now, I would be one trying to practice those things, but two, I would also be trying to think about what happens if we slide backwards in the Restore Illinois plan, and we do get pushed back into phase three or phase two in the recovery plan, and how can you continue to operate your business in a different way than perhaps you had in the past, whether that's trying to work more with limited numbers of people and appointments and those types of things so that you minimize traffic. We saw obviously the takeout food and that kind of stuff just go through the dirt and go through the roof, and outdoor eating and that type of thing. We saw lots of that. That's all good until it gets cold. and, but I think trying to think through what you could be doing in your business that would look different, because I do have just personal concern that we have a very real possibility of seeing us step backwards. There's a few rules around how we might, and of course, the number one way is just a high prevalence of testing. So, testing a lot of people helps to lower that number until there's a lot of disease in the community, and then it can come back and bite us. And I think this is where some of our increased numbers of positives, if we continue to encourage tons of testing, could actually come back and kind of sting us on the backside, because we are having a higher percentage of positives, even if people aren't particularly sick. And I'm sure everybody's got somebody within their business that got tested just because they've been around somebody or heard that somebody was sick, and the next thing you know, they've got a positive test, and you're down a worker even though they weren't particularly sick. So I think there is a real possibility of seeing us shift uh, back, at least into some of the mitigation strategies that, like what they put in region three, without necessarily moving us all the way back. The only good news in the Restore Illinois Plan mitigation strategies is that they keep you on hold for 2 weeks at whatever recommendations they had before they do a reassessment, so it doesn't change every day or every other day. So even if they do pull back and say, reduce the number of people in restaurants, or closing hours change, or those types of things, you get 2 weeks at that level before they make a determination of whether to slide even further backwards. So not quite as draconian as perhaps what the first go around with this was. So that's one of the questions that popped up is I think somebody may need to go on mute. Um, about the effectiveness of the test. There's actually several different versions of the test, and this is kind of like the testing that is the gold standard, which is kind of what we do at the hospital and what people would have done prior to surgery and those types of things, is actually about 98%, 99% both sensitive and specific for the diagnosis and testing. So it's extremely sensitive. However, there are versions of testing that's out there that are much less accurate. So some of the rapid tests are just nasal swabs and things like that. The actual sensitivity and specificity, so meaning sensitivity means that if you have it, what's the likelihood that the test will be positive? And specific means that if the test is positive, do you really have the disease? So it can kind of run both directions. So although it's a little bit different technology, I kind of liken the idea to a strep test. You know, you've had your kids or yourself, you've gone into the office for a strep test, and they'll take two swabs and they'll run one of them right there in the office, and they'll tell you, all right, well, it was negative, but we're going to send the confirmatory test to the lab, and you may get a call in a day or two saying, no, you actually do have strep. And they kind of are very much like that. Some of the lower sensitivity, if you were tested by both technologies, if the sensitivity is low, it is likely that it would miss the disease. That's even more true in asymptomatic people sometimes because at that point their viral presence, the amount of virus in their nose, or depending upon what the test site is, but normally the nose is lower sometimes until that day 3 or 4. And so we get a lot of folks that, you know, are say, hey, I was exposed yesterday and I need tested, you know, right now. And that impacts then the likelihood that a test will be positive. You know, back many moons ago, you know, home pregnancy test, they had you use your first pee of the morning because it was the most concentrated, the most likely that if it was going to be positive, that it would be. That just reflects the same type of an idea that in order for a test to be positive, you want the highest amount of virus that there can be. So, you know, the RT-PCR technology, which is what the state lab uses, the hospitals are using, those types of things are that level of technology, and they're extremely sensitive and specific. Some of the just rapid on-site testing are not so. I have not seen any published data yet from the state of Illinois, or not state of Illinois, University of Illinois saliva test. They've been very invasive about getting a whole lot of data out to people. I think there's probably a good business opportunity there. But the fact that they got an EUA, the emergency use waiver, that it is at least as good as technology of similar nature. So it's probably one of those that's going to be a, you know, 80 to 90% sensitive specific type test, but we don't know that yet. So great question, and yeah, it's a little bit a long answer, but the actual sensitivity of the big testing is very, very good. What questions do folks have? That's me rambling longer than I intended to. Norma, I know you sent me a few. I tried to work those into the presentation itself.
Yeah, I think, and maybe you touched on this. I think one of the questions everybody has is, you know, what are the long-term health issues someone who tests positive might expect to have?
So this, like I did mention, we're just now learning more about it. It's pretty frightening, truthfully. So we're seeing evidence now that folks do develop, especially those that get very sick, pretty extensive uh, scarring in their lungs that can result in long-term testing or long-term consequences. We've also seen in this population, especially while they're still sick, that they have a higher incidence of developing blood clots. It does something to ramp up the clotting cascade. And so we've seen a lot of younger folks, while they're acutely ill with it, have strokes, have heart attacks, kind of triggering that cascade of inflammation that makes people clot their blood. And so that's probably one of the most horrific complications. In children, there's actually been an identified disease called multi-system inflammatory syndrome that seems to follow this particular illness in a small percentage of cases. That looks like a disease that we used to call Kawasaki's disease, and Kawasaki still exists. We don't think it's the same thing, but it looks like it. It causes damage to the heart permanently, potentially, and we're concerned that there's going to be similar ramifications in the adult population. Certainly, unfortunately, it's still early in it, and so it's difficult for us right now to even speculate, the long effects. My only concern about that is when we begin our vaccination programs on a larger scale, as we hurry to do that, which I think everybody agrees we need to come up with a rapid solution. But part of the reason why vaccination and things like that takes such a long time to normally roll out is because you normally give it to a group of people and then you wait a while to make sure that there's no long-term consequences. It's one thing to say that it gives you immunity or protects you from the disease. It's another thing to say that after having it, that it doesn't have some unintended consequences. So, although I think there's a great need to get a vaccine rolling as soon as possible, there could very easily be unintended consequences of hurrying that process. So, great question, but yeah, we're just now on the edge of starting to learn more about what we're going to see for the long-term effects of this disease. But it is certainly not benign, especially for those that had a very severe course, just with regards to what it does to their lungs in the long term. Was a couple more questions. Back up. If social distancing is an option, what's your opinion? Employers bringing employees back to work? I'm assuming two questions there, I guess. One would be, are you talking about folks that you've currently allowed to work from home, not necessarily sick folks? That I don't have a problem with at all. I think some of the guidance that was, this is my personal opinion, some of the guidance around, encouraging people to work from home when they can makes sense. But I do know work's just not as effective, I apologize, as effective and collaborative as what it can be when we've all learned that for trying to conference call. so that part of it, I think, is okay. The second piece would be, of course, if someone had been ill or tested positive, on when to return them back to work if they're able to socially distance. Same type of thing. If someone is really completely well and you can truly socially distance, have them masking appropriately, et cetera, is probably extremely reasonable. But you do need to defer in the absence of essential worker to the guidance from the public health department around the timing of that. Depending upon what the test they had, when were they positive, those types of things. But there is exemption for essential workers. So there's a question about a flow chart. There is some guidance around what to do when somebody's had a close contact exposure and then gets a recommendation of quarantine. And it's actually kind of convoluted. This is the situation where basically somebody is well, but they were in close contact, meaning within 6 feet for more than 15 minutes of someone who's either sick or tested positive, and then the health department would direct them to quarantine. The timing of when they can come out of quarantine depends upon their last exposure to the person that they knew was sick. So in the situation, in the perfect situation, you were exposed to them day one, you never were around them again. and you go through your quarantine period, and they're using a 14-day quarantine, then you could return at day 14. The worst case scenario is that you're the caretaker for the individual that is sick, have no ability to distance yourself from them, and so then their are that the quarantine time frame does not begin until the last day that were around them, when they were still considered to be uh, uh, needing isolation. So 10 days from the start of their illness uh, to um, uh, to recovery with no fever and symptoms abating. So it's not a straightforward algorithm. They do have examples of that on the CDC's website. If you go out there, they actually have some calendar depictions of guidance on when to have a worker return. But again, this is an area where they will have been contacted by the health department with some specific instructions, and they should provide that on exactly what the timelines are for self quarantine. So, um, question about children attending daycare carrying the virus back, even if they don't show symptoms. That asymptomatic carrier state does seem to be specific, especially prevalent in the younger population. Of course, they don't tend to get as severe of disease generally anyway, and so it's very possible that children can be the kind of sneaky carrier of bringing the virus back to their family or to other coworkers, et cetera. So not a no great solution for that. I think what you've seen happen is that when there's an outbreak in a child care center, they're pretty aggressive at making sure that they shut those down, and then again are investigating the contact tracing and close source to make sure that they contain it as quickly as they possibly can. Really difficult time just for everybody around visiting grandparents and parents and all those types of things, because although children do very well with it on the whole, the folks that they spend a lot of close contact with don't always do as well. So, being attuned to what's going on in the daycare, those types of things will be, is very important. I think as we roll into fall and influenza starts to become a reality, that is going to be a really ugly scenario, because you're going to have patients and their children and adults, for that matter, whose symptoms look basically exactly like COVID, and no ability, or unless something changes dramatically, limited to get testing to sort it out. And that's going to put us in a very difficult predicament. The other bad thing, and what we've seen historically with other coronaviruses, is oftentimes someone with a coronavirus doesn't get that ill with the ones that have been around for a long time, unless they get co-infected. They get an infection with two viruses at once. And very often, especially in the children, we would see more hospitalizations, and when they're tested, it turns out they have influenza plus, one of the coronaviruses, or influenza plus RSV, and that's why they got so sick compared to normal scenario. So as we come into cold and flu season, influenza vaccination has got quite a lot of evidence and quite a long track history. This is a good year to make sure that you do everything you can do to avoid catching influenza. And actually, aside from the vaccine, the other strategies that we're using to mitigate the spread of coronavirus would mitigate the likelihood of spread influenza as well. So, with the stuff we're having to do for corona, maybe we'll have a light flu season. That would be a blessing. But definitely, vaccination and those types of things are um, uh, going to be one of those areas where, if you haven't been vaccinated for other respiratory illnesses, so pneumonias, if you're a candidate for a pneumonia vaccine, if you haven't updated your pertussis vaccine, if you get a flu shot, this is a good year to get a secondary respiratory illness, and really put yourself in a difficult spot. Specific set of vitamins around preventing COVID. Yeah, there was a lot of stuff that came out right at the beginning around zinc. It's not necessarily panned out, and I don't know if that's just because it hasn't had any real opportunity to be formally studied. The original even treatment regimens included some zinc and things like that. And they all kind of came out at the same time when they were using the hydroxychloroquine or Plaquenil, and then when Plaquenil kind of poo-pooed and said no, that's probably not a good idea. Some of the studies that were going on with some of the supplements and things like that kind of died at the same time, and I don't have an answer. Generally speaking, things that just keep you on a healthy, normal diet is the right move. We definitely know that folks that are undernourished and in poor physical condition to begin with don't do as well. So uh, that's definitely reasonable. But I don't have any specific, have not seen any specific guidance on any particular dietary supplement.
Okay, and I think you've answered about everybody's questions. I want to go back and just clarify a little bit on the issue of kind of the earlier question about returning to work and when it's safe for somebody to return to work. And you talked about whether they're an essential worker, and you mentioned fever. What about what about if they have to test? Do they have to go back and get a positive COVID test? Is that an action?
So one of the strategies to expedite somebody's return to work is to go have them test and hopefully test negative. The limitation to that has really been availability of testing supplies and testing centers. So by all means, if somebody can find a great place to go get a test for somebody that's asymptomatic, that's going to get you the turnaround, go the state facilities that, like I said, the one that's behind Building A, as well as I think the one in Clay County may not be operational right now. Coles County has one, but the backlog of turnaround time has made it almost impractical for employers, because by the time you get the results back, you would have you would have liberated them from that anyway. It might get you back a few days early, so I mean, I guess it's worth it. But there's also then the possibility that they'll test positive. The good news, if somebody tested positive and otherwise was not ill, though, is their duration of potential isolation is actually shorter than if they're stuck in quarantine because of a close contact exposure. So that could allow somebody to return faster after the 10-day isolation period. So there's two things. There's isolation, meaning you're sick now, or you are tested positive, and so you're being put into isolation. Quarantine is the idea that you were exposed to someone, and therefore we don't want you going out and potentially spreading it when you may not be aware that you're carrying it. So the public health department guidance kind of splits off on those in two different directions. But once somebody is tested positive, retesting them to say that they're cured to return to work is not effective, because we see people continue to test positive literally for weeks. So we've got examples now of people 12 and 16 weeks out. So the original CDC guidance had said, they could have two negative tests and then be, liberated type thing. And that strategy has just completely bombed because people stay positive forever. And so they changed their recommendations about 2.5 weeks ago to say go by a symptom-based strategy with someone that's been sick, has to be 10 days from when they were diagnosed or fell ill, improving and no fever for 24 hours.
Okay.
Clear as mud?
No, that was, no, it's a great answer. There's one more question in the chat box. Don't you see it? About the dangers about deliveries.
Yeah, so this really heated up in the conversations, and it just hasn't panned out. I'm sorry, I should tell you what the question is. So, asking about of things surviving on surfaces, on packages, on things that you get from Amazon, et cetera. And the reality is at this point, it doesn't seem to have panned out. They're able to detect the virus for days sometimes on the surface of things. So if I just go and swab and look for the RNA in this case of the virus, uh, you can find it. But then if you try to stick that up a mouse's nose or a monkey's nose or anything, it doesn't take off. It doesn't seem to be infective. So a lot of the concern about the surfaces and packages and those types of things has kind of backed off significantly from when it first began. And again, that reflects a little bit of the time to do the study about the idea of, in order, it's one thing to do the swab and find it on the package. It's another thing to take the time to then inoculate somebody and see if they become ill. And fortunately, the latter of that has not been the case. Although we can isolate the virus, it doesn't seem to be a pathogen. It doesn't seem to make people sick, which is part of the whole concept of don't retest a person that's been sick. So if they've been sick and they've recovered, oh, they still shed virus, but they don't seem to be contagious to anybody else. So just don't look again. Is the basis of it. Question about an employee that lives in a household with someone who's waiting on test results. Normally, they're going to isolate them pending the test result, but well, if the test result's not back, if they're sick, it's probably wise to isolate. If somebody, just went and got a test out of low suspicion or because they, were directed to do so by their employer or something, uh, it's probably not worth your time to go through the heartache of trying to do all that. So, if you're being exposed to somebody who's actively sick and has a high index of suspicion, will end up testing positive, then those folks are usually instructed to stay home. If it was just done as a mass screening event, like what the public health department did the other day, then there's no reason to isolate pending the test results. Uh, the question about the concept of herd immunity and vaccine, and are we doing ourselves a disservice by not allowing this virus to kind of break out into the community? And this is a really great question. There's a lot of speculation that what happened and why this got uh, put to this level was because it broke out in major centers. And I mean, uh, when you think about a major city, in my mind, it's the same as a congregated living facility. It's the same as a nursing home. You got people packed on top of each other. And so when it broke out in these major cities, which is what you saw, it came over on a plane, it landed in Seattle, and then the next thing you know, it popped up in the other major metropolitan areas because it could spread very quickly because they live in a congregated environment. And then the next thing you know, it overran their healthcare system, and they had a heck of a mess on their hands, and people died, of course. But would we have that same dilemma in smaller areas, smaller communities, where we don't see as widespread of disease? We certainly don't see it spread as rapidly. And if you're able to sustain the healthcare environment and you don't overrun the healthcare system, at the end of the day, that creates herd immunity, which is going to slow down that effectiveness um, that we were talking about. How many people can get sick if you're exposed to it? And even without a vaccine, it become part of the solution. Uh, that's kind of the background of the concept. That's exactly why the Restore Illinois plan actually incorporates now, because originally it did not, but it actually does incorporate criteria about how much occupancy of hospital beds there are. And other than breaking the 8% threshold, which the 8% they picked as an automatic point where they would back off. Otherwise, if you're just seeing an increasing trend in the 7-day rolling average, they actually don't count that all by itself. That has to be an and with an increase in hospital admissions and with a decrease in capacity of ICU beds, et cetera. So they did try to put some thought into that concept that a breakout in Chicago is not the same as an outbreak in rural America. And I'm relatively optimistic that in some respects that will be what spares us. That even if there's a little bit of a outbreak in Champaign County, which of course will be in our region, or Decatur, that there'll still be adequate hospital beds and things like that to keep us from tripping the lever. The other thing that can help us, truthfully, depending upon what happens with the opening of universities, is the saliva testing. And so there'll be an enormous number of tests that are getting dumped into the system, which should keep the percent positives lower unless there's a major outbreak at one of these universities. So really great question. So.
I'm going to have to interrupt. We're getting long, and I know we could go for another hour, I'm sure, answering. I want to ask you, could you repeat the reason for not isolating while waiting on results? And then that'll be the last.
If someone's well and it was just done as a screening test. So, well, another good example would be, you're living with someone who had a test for a surgery that's upcoming and they're waiting for 72 hours. The person living with them doesn't need to isolate themselves. Now that person should be isolating because they don't want to acquire waiting on, getting the procedure done and then delay their procedure. But like the health department drive-through testing that is more for surveillance, it's not really out there for people that are sick. If you're living with somebody that had that type of testing, no reason to isolate yourself. If you're living with someone who's ill and you're really suspicious they have it, then you should be pending the test result.
All right, great. There are a couple other questions, and what I recommend. I know people still have questions. If you want to send us your questions, we will have Dr. Jennings answer those, and we will include those with the recording of today's webinar. So thank you, Dr. Jennings. What great information! Lots of stuff to think about, and lots of things for. I think as a community, we need to work together to make sure that we keep our numbers under control. Of course, we're based on what happens in the whole region, which is good for us. But obviously in Effingham County, things are getting a little dicey right now. So thank you so much. Thank you all for joining us today. I hope you were able to get most of your questions answered. We want a special thank you to Acro Builders, our webinar sponsor. As I mentioned a while ago, this webinar was recorded. We'll have the webinar available tomorrow, the recording available tomorrow in the Chamber's Business Advocate and on our YouTube channel. Next week's webinar will be on Thursday, August 27th at 9 a.m. We'll hear from Matt Seconder, CPA with Doring Winders and Company, and Mel Stock, Market President of Midland States Bank, who will be sharing program updates and tax implications of COVID-19 relief programs. And then just a reminder, tomorrow we have the start of a 4-part webinar on a community conversation on keeping Effingham County safe. I would strongly encourage many of you to sign up for that. Great opportunity, excuse me, great opportunity to share ideas, best practices, what you're doing in your business, what we can work together as a community for. We'll be sending that reminder out today, but that will be a great opportunity to have this conversation. Chamber's also has created a Facebook group on this topic on community conversations. So if you go to the Chamber's Facebook page, you can join that group and start sharing ideas and have that conversation. That webinar tomorrow starts at 9 a.m. and you can register through the Chamber's website. So thank you so much. Thank you, Dr. Jennings, for a great presentation. Enjoy the rest of your day, and we'll see you next week. Thank you.
Thank you for the opportunity, Norma.
Well, thank you, Brian.